so I have no disclosures. So clinical vignette of this patient is a 69-year-old gentleman who has a history of ischemic MR and a recurrent heart failure admission in the past. He was operated in 2011 in Florida with three bypass grafts and a Physio 2 ring. Has a very rocky post-op course there. Was on a transplant list for some time, home renal, etc. He has emphysema with DLCO that's moderately depressed, liver cirrhosis, not that bad, but still has a class A. Cardiomyopathy of about 30%, pulmonary hypertension, PA pressure by echo in 90s. ICD implant, abdominal aortic aneurysm. Came to our structural clinic from our heart failure group, and he was showing up every week, almost in the hospital for a heart failure admission. They will diurese him, send him out in 1 to 2 days, and come back. This is his preoperative echo. If you look at this, the first clip on the left side, you see there's a small flail segment, but the jet is very wide, so we thought there's more than one thing going on. And you can see there's density in the middle of the valve. I don't think there's any question that his MR is not severe. And the ring is almost 270 degrees. This is the LV view of the mitral valve to better understand the pathology, what's going on. And the jet is pretty wide. All his pulmonary veins look like this. All of them have a reversal, and his PA pressures on a preoperative echo buzz, TR jets are about 83. So we have a heart team meeting. We talk about reoperating on this patient versus clip. We all agree that we shouldn't reoperate on this gentleman. So we planned for mitral clip. We had a few considerations before we tackled this case. We wanted to get the highest transseptal puncture so we can steer better. Now the question was, you go inside the ring or you go behind the ring? Where do you align your clip arms? So we decided to align the clip arms the highest possible above the ring, and then close the clip, go through the ring so we don't catch anything from the ring fabric, and then go under the LV, recheck our orientation, make minor adjustments if we have to, and see what happens. Now there was 2 jets, if you remember from previous images. There's one was on the middle and one was a little lateral. So our goal was to go in the middle, see what we got. So we went with our plan. We got lucky. We were able to align the clip above the close it, go inside the LV. We made some adjustments. We moved because thank God we went close because we had we could feel that we are touching the ring. We aligned an A2P2 in the reverse or LV view of the mitral valve and placed the clip. This should play. Okay. So this is after first clip. Our gradient is about 3.3. And this is all our pulmonary veins look like. And I'm going to go back to the slide where we have this MR jet is a blood pressure of 139 over 68. Heart rate is about 62. So Dr. Suraja, go for the second clip or call it a day?
I don't know. I think that's a pretty darn good result for the first clip. You could call it a, but you know, it wouldn't be unreasonable to put another clip in if you want.
So I was trained by Dr. Suraja, so we called it a day. So this is the 1-month echo in the clinic. You can see there's a minimal MR. Dr. Bay, would you call it mild to moderate or mild? Something like that?
Yeah, it doesn't look too bad there, mild to moderate.
It's impressive, the pulmonary vein, the changes in the pulmonary vein you got right away.
Yeah.
That was really impressive.
So this is PA pressure on a 1-month echo, about 29. If you remember from the previous slide, it was 83.
Wow.
And the patient remains active, no more heart failure admissions. I checked before I came in our heart failure team notes, and they classify him in NYHA class 1 to 2 symptoms. These are my co-procedural structural and another interventional, Dr. Morfer and Dr. Hayes.
Great.
And that's him. He gave us permission to